He has completed his super specialization from Graduate College Hospital. He also successfully commenced his fellowship training at the University of Tennessee, where he received the opportunity to work with the leading doctors in the field of laparoscopic and thoracoscopic pediatric surgery. And his pioneering work in the minimally invasive surgery in children has made him the recipient of several prizes. His field of expertise are laparoscopy, surgery, and urology. A very warm welcome, Dr. Rasik. Please start your talk. It is on abdominal pain in children.
Okay. Thank you, Shruti, for the nice introduction. And at outset, I thank all the participants, participants in the sense, one sec. Yeah. Of the masterclass. We have completed almost 3.5 years plus organizing this masterclass. Earlier it was physical, and then for last 2 years plus it has become online. We were the first one to start online masterclass. That was June 2020 when the COVID was going on. At the time we started, and since then it is continuing with minor variation. Today's first talk was supposed to be given by Dr. Supratim Sen, but there was some confusion, and he will be giving talk in September. So the first hour was vacant, and I had given this same talk about 1 year back, few months back, last year, May. So this is very important topic, so I'm going to repeat it, and I'm sure it will be helpful in understanding of abdominal pain to all the consultants, family physicians, pediatricians, whoever is attending the class. So let's go through the our presentation. So what is the anatomic basis of pain? So there has to be receptor to feel the pain. So sensory neuroreceptors in abdomen are located in mucosa muscularis propria of hollow viscera, on serosal structures like peritoneum. It is there in the mesentery also. So this sensory neuroreceptors involved in regulation of secretion, motility, and blood flow. Then there are two types of nerve fibers which are involved in perception of the noxious stimuli. So which are they? They are myelinated A delta and unmyelinated C fibers. Now, myelinated A delta fibers are found in skin and muscles, which mediate sudden, sharp, well-localized pain following any acute injury. And more important for us is C fibers, which are found in muscles, periosteum, mesentery, peritoneum, and viscera. Now, these fibers basically will give rise to pain, which is usually dull, burning, poorly localized, gradual onset, and long duration. And this is the kind of pain which many of us have felt at some point in our life. And the same thing is felt by our patients also. Now, what are the stimulants? What will give rise to the abdominal pain? So abdominal visceral nociceptors respond to mechanical and chemical stimuli. The principal mechanism is a stretch. If any hollow viscera gets stretched, then we will get the pain. The cutting of the viscera, tearing, crushing will not give rise to the pain. The pain is because of the stretching. Mechanoreceptors stimulated with rapid distension of hollow viscous, like in intestinal obstruction, will give rise to pain. Forceful muscular contraction in biliary, renal, and intestinal colic. So basically, we will feel colicky pain because of the muscular contraction of these structures. And usually it is because of the distal obstruction, all this structure will have colicky pain. Now, rapid stretching of organ or capsule like hepatic congestion will also give rise to the pain. So the pain in abdomen can be because of any of this structure. Then what are the types of pain? The visceral pain or visceral nociceptor triggered, it is generally felt as dull, poorly localized pain. And if it is in midline epigastric region, it is arising from foregut. If it is periumbilical, then midgut. And if it is lower abdominal, then it is hindgut. Usually there is crampy, burning, gnawing type of pain. The somatoparietal pain, the noxious stimuli to parietal peritoneum. So anything inflamed which comes into the touch of the parietal peritoneum can give rise to the pain. So any inflamed tissue like appendix will give rise to pain in the right iliac fossa. If the gallbladder is intensely inflamed, then it will give rise to the pain in the right upper quadrant at Murphy's point. And there is last is the referred pain, and referred pain will occur because of the nerve supply which is common. So for an example, pain felt in the areas remote to the disease organ. So subphrenic abscess will give rise to the pain in the shoulder area. And that is because of the diaphragmatic irritation, and shoulder is also supplied by C4-5, and the same diaphragm is also supplied by the same nerve roots. So that is the pain which will be referred there. Then location of pain. In epigastric region, as I told you, foregut means stomach, duodenum, gall, which includes even gallbladder and pancreas. Midgut will include small bowel and large bowel up to the right part of the transverse colon, and small bowel mesentery and lymph nodes. All this, anything inflamed in this area will give rise to pain in the umbilical region. In hypogastric region, it will be from the large bowel after mid transverse colon and urinary bladder. And last area will be the renal angle, and that will be because of the kidney. The radiating colicky pain or ureteric colic will be, if it is arising from the kidney, it will start in the renal angle and come anteriorly. If it is in the ureter or mid-ureter, it will be from lumbar area to the lower abdomen. And if it is in the lower ureter or near UV junction, uretrovesical junction, then the radiation from one side of the tip of the penis due to stone in the lower ureter. So from the lower abdomen, it will go to the tip of the penis, and that is classical of the stone in the lower ureter. Now, it is very important to have a history, obtaining a correct history, because that will lead us to the area of interest or from where the pain is originating. And accordingly, then we can guide the patient to undergo the investigations. So if there is sudden onset, well localized pain, and that is basically, it is because of something which has happened intra-abdominally. For an example, perforated viscous, mesenteric infarction, or ruptured aneurysm. So in all these conditions, it is a sudden event which is happening. So the pain will be sudden onset and well localized. Then there will be something which is progressing. So appendicitis will start with little inflammation, and then it will keep on increasing. So the pain of appendix will keep on increasing unless the later part, it may subside, or we will go ahead and operate, depending upon the condition of the patient or what the parents or family wants. The gastroenteritis, the pain will start and then it will slowly die down. In colicky pain, it will increase and decrease. When the colic comes, the patient will have pain and then it will slowly go down. Duration of hours to days, because that will give us some idea whether it is acute onset, chronic pain, and depending upon that, you will decide what kind of investigations are required. Obtaining a history, continuing. So location, the most important part is where the pain is. Often when you ask the child, they may not be able to pinpoint at one place, and they will say show the entire abdomen. So often it is non-specific. Pain of diaphragmatic irritation will present as shoulder pain, which we have already discussed. Change in location may be marker of progression or visceral to parietal irritation. So all of you know that the pain of the appendix will start at umbilicus, because initially it is just because of the stretching of the appendix, and the later, once the parietal area or the once the appendix is inflamed completely and it start touching the parietal peritoneum, then the pain will shift into the right lower quadrant. So when there is a change in the location of the pain, you know what kind of disease it's likely to be. So appendicitis, McBurney's point, perforated ulcer will give rise to wake pain and peritonitis. Then we always ask whether there is any aggravating or alleviating factors. In peritonitis, when the child is, they lie motionless, they are listless, they don't want to move because with the movement, the pain increases. If it is colicky pain, then patient is unable to sit or lie down without any motion. They will keep on, they are uncomfortable. They will keep on moving in bed or wherever they are. So they are uncomfortable when they have colicky pain. If after fatty foods, if the pain is coming, then it is because of the biliary colic. If pain improves with eating, then it is because of the duodenal ulcer. And if it is worse with eating, then it is either gastric ulcer or mesenteric ischemia. Then we ask about the intensity and character. So perception of intensity is dependent on the point of reference to the patient, and usually it is not very useful. Then we always ask about past medical history. So if the child had bowel obstruction, which is recurrent, then the reasons will be the different, whether it is any renal surgeries has been done or renal colic had come, or there is any pelvic inflammatory disease. And all these conditions are likely to recur, whether child had any surgery in past, because surgery means it can be adhesive small bowel obstruction and the pain may be related to that. Then we ask about other symptoms like whether there is any fever or chills. It means there is infection somewhere. Any infection, whether it is in gallbladder, whether it is in appendix, whether it is in small bowel, all this can give rise to the pain. Whether there is associated nausea, vomiting with or without flatus. So if it is without flatus, then it is suggestive of bowel obstruction, particularly if the vomiting is bilious. So any bilious vomiting, you can't take it lightly, whether it is in newborn or in the older child. Bilious vomiting, by and large, is the surgical cause, which is distal to the ampulla of Vater, and it should be treated on urgent basis. If there is associated dysuria, it will point towards the pain, origin of pain into the kidney ureter bladder. Of course, in older girls, always ask about pregnancy and menstrual history. There can be ectopic pregnancy in a 15, 17, 18, 19-year-old, and we should not be fooled. So always ask about menstrual history and whether there is any missed period. Then it's the physical examination. When you look at the patient, a lot of things you will realize where the pain is, whether it is significant or insignificant. If the patient is lying still, listless, it means that there is probably associated peritonitis and it is grave. It needs to be looked into immediately as early as possible. If the patient is unstable, breathing in the bed, it is colicky because of whatever. We have already discussed colicky because of intestine, biliary or urinary tract. So any of this can give rise to similar pain. Remember, the old and young may present very atypically. Elderly, diabetic, immunocompromised may present with minimal symptoms. So if somebody is on steroids and if he is not complaining of much of pain, I mean, even after perforated bowel and peritonitis, they may not have pain. So if the patient is on any medicine like steroids or any other medicine which can cause immunosuppression, then one has to be careful because the symptoms may not be a lot, but the inside there may be something which is going on very badly. Severe tenderness with rigidity means peritonitis, and urgent surgical consultation is mandatory. If it is mild tenderness, it can be because of gastroenteritis. Then if patient is complaining of pain in the right lower quadrant, we don't go and immediately palpate the right lower quadrant. You will start palpating from the most away area, means you will start on the left side and slowly you will come onto the right side. If there is peritonitis and if the bed is shaken or the child takes deep breath, the pain will increase. Then pelvic, genital and rectal examinations are also very important for evaluation of severe abdominal pain. We have had patients where we have diagnosed that patient has pelvic abscess on clinical examination. Then you can confirm it on sonography. Often sonography may not be able to tell you whether there is appendicitis or not. They can tell us collection is there, but you can also clinically diagnose the presence of pelvic abscess on rectal examination. Then laboratory evaluation, CBC we do to identify whether there is any leukocytosis or not. Urine examination to see whether there is any urinary infection. Electrolytes, particularly if the child is vomiting, so it helps us in treatment and then anesthesia and post-anesthesia recovery. In elderly girls, after 15, 16, 17 years, it is better to do even pregnancy test if you are in doubts. LFT, amylase lipase, particularly LFT for gallbladder or pancreatitis, amylase lipase also for the similarly for for pancreatitis. Then radiographic evaluation is also very important. We do plain radiograph to look, it should be upright and supine, ideally both, along with the X-ray chest. So you will see whether there are any fluid levels, whether there are any appendicolits, whether it is just a gaseous distension, what is the size of the loops. All this will give us some idea whether it is arising from the bowel. Sometimes you may be able to see the stone in the kidney or ureter or bladder. So plain X-ray also is very important. Then comes the ultrasound. Ultrasound is the main investigation for evaluation of abdominal pain, and it can tell us about a lot of things. But you have to have a good sonologist, good machine for the actual evaluation. They can pick up appendicitis, cholecystitis, bowel obstruction, any collection anywhere. So all this can be picked up on sonography. If there is any doubt, then one can do CT abdomen and pelvis. It will tell us about evaluation of vasculature as well as inflammation of any organs, including solid organs. Now, when to refer? If any pain is more than 24 hours, it is better that you refer to the surgeon. And if it is colicky, not relieved by simple medication, then it should be referred. If there are any association with vomiting, fever, on clinical examination, if there is abdominal guarding and rigidity, if there are urinary complaints, if there is bleeding from GI tract, jaundice, child looks sick, I think it is better to refer to surgeon or at a higher place. Now we will discuss about some of the conditions which we see and how we will manage. So if a 9-year-old boy comes with a history of acute abdomen, with the pain in umbilical area, the duration is of about 6 hours. There was some associated nausea and one vomiting. There is no fever. On examination, there are no lower GI or urinary complaints. On abdominal examination, there is mild tenderness in right iliac fossa. Now, when there is a mild tenderness in right iliac fossa, one has to remember it can be very early appendicitis, or it can be typhlitis, it can be mesenteric adenitis. It is difficult to say at this stage what is to be done. I mean, what is the diagnosis? So one may treat it conservatively at this point with paracetamol or some painkiller, and call the patient again after 6 to 8 hours or next day. And if there's any doubt of appendicitis, one may get the sonography done at this level. And if you treat it conservatively, and if the pain persists, and if vomiting increases, then at this point, what should be done? Probably appendicitis should be on card, and one should investigate the child. Apart from appendicitis, it can be urinary infection, amoebic typhlitis, salpingo-oophorytis, or primary peritonitis. So any of this can be the differential diagnosis. So on investigation, what we see is if there is a marginally raised WBC count, it will be favoring the appendicitis. So the count of 12, 13,000, 14,000 suggests the possibility of appendicitis. And the neutrophil will be high, like 65, 70, 75. This is in case of appendicitis. But if it is something else, then there may not be, for an example, if the child is typhoid fever, then the count will be less. So that this helps us in identifying the cause. Even in urinary infection, the WBC count will be higher, but that will be higher than even 15, 16,000. So marginally raised WBC count will favor appendicitis in early stage. Once the appendix is perforated, most of the time, the count, WBC count will be increased to more than 16,000, and neutrophil will be more than 80% in most of the patients. There are always exceptions to the rule. Or if we do urine examination, if it is normal, there are no pus cells, then by and large, it will rule out the presence of urinary infection. If we do sonography, and if the patient has appendicitis, one can see tender tubular structure without peristalsis. The important is without peristalsis. Diameter of more than 5 to 6 millimeter. So in a children, by and large, if it is more than 6 millimeter, you can safely say possibility of appendicitis. If it is less than 5 millimeter, probably it is normal. There may be associated thickened bowel loops in the right lower quadrant. There may be free fluid in abdomen. There may be probe tenderness. There may not be anything else. Sometimes appendix may not be picked up on sonography, particularly if it is pelvic or if it is retrocecal. In such a condition, if we do CT abdomen, it will be helpful. So what we'll do if the diagnosis of appendicitis is confirmed, then we will admit the patient. We'll start on IV fluids, IV antibiotics, analgesics, and surgery. By and large, the standard treatment is laparoscopic appendicectomy. Now, there are some papers which are published of conservative treatment, but conservative treatment, there is no guarantee that it will settle down in all patients, and the chances of the patient coming back with the abdominal pain or appendicitis are high. So we will prefer the patient undergoes the surgery, and with laparoscopic surgery, by and large, they do well. In the sense, if I operate today morning, next day evening, by next day evening, or latest by, let's say, 2 days or 48 hours, they are discharged. And once they are discharged, there is no anything to worry about. Particularly when it is done laparoscopically. There are 3 small cuts and they do well. If we treat it conservatively, then we have to make sure that there are no complications. Their hospital stay most of the time increases. And if there are complications, then the further stay is increased. So the standard treatment will be laparoscopic appendicectomy in case of appendicitis. If the family is not ready or if there are other issues, one may treat it conservatively. I will show you one small video clip of a 5-year-old girl where we did laparoscopic appendicectomy. This is 3 millimeter port. So what you can see is that there is some inflamed tissue around in the right lower quadrant. That is the colon. That's the appendix. That's the omentum, which is on the stuck onto the appendix. There is fibrinopurulent material on the appendix. This is monopolar hook. It is very precise. And we are coagulating and dividing the appendicular vessels using hook. So this patient mother also had appendicitis, and she exactly knew that the child has appendicitis. They were in some farmhouse at Karjat. They came, and within 3-4 hours we operated. That was Saturday evening, and Monday morning the patient was discharged home. So that's Maryland. We are crushing the base of the appendix. There is a fecolith there. Now, when there is a fecolith, and if they are not operated, then it can perforate, and the perforation can happen within 24 to 48 hours. So which patient will have fecolith and which patient will not have, we don't know. So we had put 2 endoloops. That's the bladder. We are doing suction irrigation. This was in a girl. So if not operated and perforates, then it can even give rise to pelvic inflammatory disease with infertility. So that appendix is divided. We will put it in thumb glove, which has been placed through the 5mm port. So here the camera was 5mm and 3mm instruments were used for removal of the appendix. In an older child, we used 10mm scope and 5mm instruments. And then this has been removed. So there's 3 small cuts and appendix is removed. Yeah. One there, and one there. The advantage of laparoscopy is even if the appendix is anywhere located location-wise, we can remove the appendix through these cuts, three ports by and large. We have never put the 4th port, and most of the time we can do it laparoscopically. In last 20 years, maybe 4 or 5 cases we had to convert, but they were really bad ones. Most of the even bad ones we can remove it laparoscopically. This was a retrocecal appendix. You can see it is how badly it is adherent, and this was in an older child. So what we are going to use is something like harmonic scalpel. So this is the omentum which was stuck there. So this is a special instrument known as harmonic scalpel, which vibrates at the frequency of 55,000 per minute, and it does coagulation of the tissue. So the rest of the procedure remains the same. So this is like retrograde appendicectomy. We are starting from the base of the appendix and going towards the tip of the appendix. And you can see that's the liver. The tip is lying almost near the liver. If we were doing open surgery, the incision for such a surgery will keep on growing. It will start with 4-5 centimeter, and then by the time you complete the surgery, it may be 10, 12, 13 centimeter. And that's the tip. So the rest of the surgery remains same. Put the endoloops, divide it. If required, do suction irrigation, and then go ahead. The case scenario 2, 2-month-old baby comes with excessive crying, more in the evening, and child stops crying as soon as you take the child in your hand. There are no associated complaints. So this is classical of infantile colic. And what they need is just symptomatic treatment with paracetamol, Policaid, or whatever you like, you can give. Occasionally, I have given even sedatives. So if nothing is working, you just make child, you give trichlorphos or pedichloril and let the child sleep. So everybody is at ease. The patient also sleeps, parents also sleeps, and they are fine. So this is classical. It's very common, and most of the pediatricians, all consultancies, this, and those who are already parents, they would have also experienced this with some of the childs. Then the third condition we will discuss is a 9-month-old boy presents with intermittent acute colicky abdominal pain, along with vomiting and blood in stool. So this classically at this age will be suggestive of intersusception. So intersusception is a condition where the small bowel or the proximal bowel goes into the distal bowel like telescoping. So that is intersusception. And what they have is a blood in stool, also known as current jelly stool. So it is blood mixed with the mucus, and that is suggestive of uh, intersusception. If we do sonography, then there is something like target sign. You can see this is a classic target sign. So most of the time it is idiopathic variety, in the sense there is no lead point. Occasionally there is a lead point. You can see here there is a lead point polyp. So then if there is a lead point, then you need to remove the lead point. And here in this patient with the polyp, we did laparoscopically identified, extended the incision, and delivered that loop and took out the polyp and closed that enterotomy. Of course, the age of presentation of this secondary intersusception, not the idiopathic, will be 2, 3, 4, 5. So classic is up to 1 year or infant. If anything is beyond 1 year, or if it is recurrent, then one has to think about the lead point and treat accordingly. However, in case of idiopathic intersusception, what we do is, once it is diagnosed on sonography, we do hydrostatic reduction using sonography and saline. Saline is placed under pressure and the intersusception is reduced. We usually do under sedation, midazolam is given and then we do it. Most of the time we can reduce. If we can't reduce, then the possibility of it being gangrenous part is high, and then they will need surgery. Surgery can be done laparoscopically or open. Most of the time, if the gangrenous bowel is there, then we can't reduce it laparoscopically, and then they will need open surgery. Of course, this patient is not idiopathic variety. This is being done in a older child. This was post-operative. Patient was operated for Wilms tumor, and he developed obstruction. And we went in with the diagnosis of adhesive obstruction. But to our surprise, what we found was the small bowel obstruction. And this is a small video clip showing that small bowel intersusception. So now that intersusception area is coming in the view. So yeah, you can appreciate that. So there's the proximal bowel going into the distal bowel. And we could reduce it laparoscopically. There was significant part of the small bowel which had intersuscepted in the distal bowel. Yeah, so let's move fast forward. So it is reduced completely, and this child did well post-operatively. We could start feeding next day. Case scenario 4, 3-year-old boy presents with 12 hours history of vomiting, epigastric pain, and mild fever. On examination, there was mild tenderness in epigastric region. At this point, we diagnose it as a gastritis. Whether it is viral or bacterial will be difficult to say, but the treatment will include lansoprazole, mucin gel, or any other antacids. Oral antiemetics like perinom, domperidone, or ondansetron can be considered. Now, some of these patients may develop loose motions after 6 hours or 8 hours or 12 hours. So diagnosis will be gastroenteritis, and you can treat it according to whatever is your protocol. You can add antispasmodic probiotics, and rarely, if required, one may give antibiotics. So case scenario 4, we continue. 4-year-old patient presented with abdominal pain, vomiting, and fever. The chronology of symptoms may be different. So if patient comes with pain, vomiting, fever, it is classical of appendicitis. Now, if the child comes with vomiting, fever, and then the pain starts, then it is very unlikely to be appendicitis. So chronology of symptoms is very important. If it is not abdominal pain, vomiting, fever, you have to start thinking about other causes of pain. Now, along with this abdominal pain, vomiting, fever, if the child has acute bleeding perrectally, which is profuse and painless, or if there is perforation peritonitis, then you have to start thinking of something else. It's not a classical appendicitis. Now, we have seen the patient who comes with similar problem, and clinically, we can say that it is probably Maker's diverticulitis, and then we investigate accordingly. One can do Cbc urine examination, as we discussed earlier, to look for the signs of infection. If we do X-ray abdomen erect, there may be minimal gas under diaphragm. Now in appendicitis, usually you don't get any gas under diaphragm. But if you get gas under diaphragm, it means there is either some kind of perforation, like Maker's scan, means Maker's diverticulitis with perforation is a possibility. One can do sonography, CT scan to differentiate from appendicitis. If it is not bad and if the facilities are available, one may do Maker's scan at that point. But one should remember that in acute Maker's diverticulitis with bleeding, one may not get positive Maker's scan even if the Maker's diverticulum is present with ectopic gastric mucosa. The scan may be still negative because this mucosa, gastric mucosa can slough out at that point. So if you think that diagnosis of Maker's is there, you go in and do surgery.
Presented to us with bleeding.
So this was the child where you can see that's the Maker's diverticulum. So we did it laparoscopically, mobilization. That's the laparoscopic. That's the on the mesenteric side. Whatever vessels are there, you divide it, and then you deliver from the umbilical area and take it out. This is another patient where patient had Maker's diverticulitis. You can see there is a pus. Now, clinically, we thought it is Maker's diverticulitis. So we looked at the appendix, which was normal. So we went from terminal ileum proximally, looking for the Maker's diverticulitis. So as you go further, as you know that Maker's is 2 feet away from the ileocecal area. It is 2 inch in length, 2 feet away, 2 inch in length. So you can see there is a pus there. There is the small, the omentum has come there and stuck to that area. Something is going on over there. And as you dissect it out there, you will see the Maker's diverticulum. So you can see there is a Maker's diverticulum there. Yeah. You can see pus over there, and that's the diverticulum. So we do devascularization laparoscopically, and then either you can take it out from the umbilical area or you can fire the stapler. So last 5-6 cases, we have fired the staple and took it out. The fifth condition we will discuss is someone like 10-year-old boy who comes with acute onset of severe epigastric pain with vomiting, fever. There is tenderness and rigid upper abdomen. Then the diagnosis of pancreatitis, apart from gastritis, cholecystitis, one has to remember. And one has to send the amylase lipase. Any abdominal pain, particularly epigastric area, we have to send amylase lipase. Sonography may be non-specific because it's a retroperitoneal organ. One may not be able to pick up the pancreatitis, or they can show us it is bulky pancreas with or without gallstones. If you do CT scan at this point, or one may see the collection which is behind the stomach. So this is like pseudocyst of pancreas. Of course, this is on the chronic It's not acute stage. So that is suggestive of pseudocyst of pancreas. And if you do MRCP, you will know if there are any other issues. The treatment by and large will be immediate admission to the hospital, IV fluids, IV antibiotics, somatostatin, if needed, nasojejunal tube feeds. If the pancreas develop necrosis and if the child is not doing well, is septic, then we may have to do debridement, which can be done laparoscopically. And if there is no expertise available, one may do open also. And if pseudocyst develops, then one has to do cystogastrostomy. Now, cystogastrostomy can be done using a minimally invasive technique of laparoscopy. If facilities are not available, then one can do it open. Then continuation of our case scenarios. 7-year-old boy coming with acute abdominal pain. There is vomiting, which is severe and bilious. If it is feculent, then it means obstruction is much distal. If there is, along with that, there may be constipation. There may not be any fever in early stage. Once there is peritonitis, the child may even have fever. The abdomen will be distended, tenderness will be present all over. There will be hyperperistalsis on auscultation. Now, it can be because of anything of this. There can be herniation giving rise to small bowel obstruction. There can be adhesions, maybe because of the previous surgery. There can be volvulus in presence of patent vitellointestinal duct or any other inflammation can lead to volvulus. Even in malrotation, you can have the similar finding or intersusception. So all these are the causes of small bowel obstruction, and we have to go with the diagnosis of small bowel obstruction. So commonest cause is adhesive obstruction, but we don't see any more adhesive obstruction that commonly because a lot of surgeries are being done by minimally invasive technique. So the incidence of adhesive obstruction has decreased significantly. And if open surgery, fundoplication, aphasia, cardia, all pull-through surgeries are done open, the chances of obstruction are in the range of 5 to 8%. So all that is avoided when we do it laparoscopically. Incarcerated hernias, always check groin in any infant because there may be hernia sitting there giving rise to obstruction. And if you miss that, that will not be good. There will be fluid levels like this, particularly when you have J-shaped fluid level, it means there is acute obstruction and this patient by and large needs an operation. And if the abdominal distension is not severe, one can attempt it doing laparoscopically. If there is severe distension, one can just go ahead and do standard laparotomy. If there is a free gas under diaphragm, it means there is already peritonitis set in and you have to go and operate, whatever, lap or open. Management of small bowel obstruction, most of the adhesive obstruction are due to adhesions between incision and small bowel or between the loops or omentum and bowel or mesentery. The advantage of laparoscopy is no incision and hence the chances of recurrence of adhesions are less. 14-year-old girl presenting with severe lower abdominal pain on right side. So one has to start thinking about gynecological conditions. There may be associated occasional vomiting. There may not be any fever. History of dull ache for few weeks may be there, may not be there. On examination, no evidence of any area of tenderness or guarding. Now, any severe pain, and if the patient is restless, it means it's a ischemic pain. Now, ischemic pain in a girl who is 14-year-old, so clinically it is an ovarian problem unless proved otherwise. So ovarian cyst with torsion or even without the cyst, the ovarian torsion without cyst, both are possibility and one has to remember that. And then these are the, this patient needs to be operated early enough so that you can relieve the pain. So we will see this one of the patient with ovarian torsion. Now this patient did not add any cyst. It was just a plain ovarian torsion. We are assessing the opposite side, whether that's the uterus. Now you can see that there is a torsion there. So the torsion was relieved. Now, whether this should be fixed or not, there are two schools of thought. Some people fix it, some people don't fix it. In this particular patient, we did fixation. The other says that once you do a detorsion, it will automatically get adherent because there is some inflammation is already there. The other causes of abdominal pain, I mean, the pain in the lower abdomen will include tubo-ovarian inflammation, tuberculosis, endometriosis, and ectopic pregnancy. Here you can see we are stitching the ovary with the back of the or the lateral wall of the abdomen so that we can avoid the, so that we can avoid recurrence. Though I have not seen recurrence, but some of our colleagues have seen the recurrence of torsion on the same side. But either way, it can be treated. There is another scenario. 12-year-old girl presents with the pain in the right upper quadrant. So girl, right upper quadrant, along with that fever, pain also present in the right scapular area. So all this points towards the gallbladder. There may be associated vomiting. If you do clinical examination, Murphy's sign will be positive. The investigations include Cbc, LFT, amylase, lipase, and this may be deranged. On sonography, MRCP, if we do it, we may see cholecystitis or choledochal cyst. Both the things are possible, and that will be the sonography, MRCP will tell us what is the exact diagnosis. If it is cholecystitis, if they have come early enough, one can go ahead and take out the gallbladder in the inflamed stage in first 3-4 days. If they come at 7-8 days, then better to wait for at least 3 weeks because it's very difficult to remove the gallbladder and day 8 of inflammation. If it is choledochal cyst, one can do laparoscopic excision with Roux-en-Y hepaticoenterostomy. So this is like a normal ERCP, and this is in a choledochal cyst. There's a large CBD. These are 2 short video clips, and then we will end. So this was an interesting patient, 7-8-year-old boy who was diagnosed with peritonitis. With clinically, it was appendicitis. The abdomen was completely rigid. When we went in, the appendix was normal. And when we turned the scope in upper abdomen, we could see the inflamed, bad gallbladder, which is necrose at multiple points. Now, that's the advantage of laparoscopy. Now, if you were doing open surgery with the diagnosis of appendicitis, it would have been very difficult to pick up cholecystitis. You can see it is all full of pus. It was acalculous cholecystitis. So we took out the gallbladder. Of course, this was a difficult operation in an inflamed tissue. So that's the cystic duct, which is ligated, clipped, and then divided. And this is choledochal cyst. So choledochal cyst is a dilated common bile duct giving rise to cholangitis. Cholangitis means fever, pain in upper abdomen with jaundice. So that is suggestive of cholangitis, and then one has to go in and get rid of it after the inflammation subsides. So this is the duct or choledochal cyst which is being dissected off. Posteriorly, there is a portal vein. So that's the end of the choledochal cyst towards the duodenum, where it opens into the duodenum. Then it is divided. And then it is anastomosis is being done. Of course, here we have done hepaticoduodenostomy, but today it is preferred to do hepaticojejunostomy, Roux-en-Y hepaticojejunostomy. Okay, we will stop at this point. only last one slide I'll show you. The chronic constipation also can give rise to a lot of pain in children. And it is generally because of the diet. They have very hard, dry stool and difficult for them to pass, and it is very painful. And all of us see this condition very often. Once the child becomes constipated, she may avoid using bathroom to avoid discomfort that may come simply from passing the hard stool. So they keep on holding, and then there will be overflow like encopresis. Some of them will present with urinary symptoms. Even though they have constipation, they will come with the urinary symptoms. And the important thing is the diet. If they have high fiber diet along with, so the management will include bowel training, suppositories and enemas for the bowel training, oral laxatives, diet high in fiber, fruit and vegetables should decrease the water content in the milk if they are taking formulas, increase the powder quantity. If required under anesthesia, rectal biopsy with sphincter stretching. Usually it takes 3 to 6 months for child to have normal bowel movement. Thank you very much. So I will stop my screen share at this point. If there are any questions, I will be more than happy to answer. There are 7-8 minutes left.
Thank you so much, Dr. Rasik. That was a very extensive and an excellent talk. I request all the participants, if you have any questions, you may ask.
Sir, in pediatric otalgia, how child presents? Continuous crying, or when we pick up, then just in the abdominal colic, child stops crying while picking up. Then how can we differentiate otalgia from abdominal colic?
Abdominal colic versus which condition did you say, madam?
Otalgia.
Otalgia. I mean, that Shruti can tell how to diagnose otalgia.
So usually, patients with otalgia will have history of some form of cold, and the child will keep on touching the ear again and again. Because otalgia in children is mainly because of the eustachian tube swelling or edema or locking, and they keep on feeling the discomfort in the area below the ear. So they keep on touching their ear, and also they have a history of some form of cold also. So that is one thing that gives you an idea whether the child is having otalgia, or if not, then it is mostly.
Sir, what analysis? Hello.
Yeah, Vinay, Dr. Vinay Desai.
Yeah, sir. What analgesic can be given in the primary stage for appendicitis and all in children, pediatric age group?
So I give only paracetamol to start with. And if the pain is a lot, we do give diclofenac suppositories once in a while. And beyond that, if the patients are admitted, then we give Dynapar, fentanyl and whatnot. But on OPD basis, by and large, it is paracetamol. If required, ibuprofen, diclofenac suppositories.
Sir, Dr. Mulchand here.
Yeah.
Thank you for the excellent session. Sir, what is the incidence of appendicitis in children less than 10 years of age? Say, out of how many abdominal pain it turned out to be appendicitis?
So appendicitis has become quite common in this particular age group. When we say in a small child who is like 3, 4, 5-year-old, it is not very common. Below 3 years, it's not very common. But above 4, 5 years is quite common up to the age of whatever age. So earlier it was not very common because of the diet, which was having high fibers. Today, with a lot of junk food which has been eaten by the kids, the incidence of appendicitis, particularly in upper middle class and upper class, has increased significantly. And all of us, particularly in private practice, do see acute appendicitis quite common. It's not uncommon. I may not be able to give you the percentage because my practice is surgical and we get mainly surgical patients. But if you ask pediatrician, that may be a relevant question, and it may not be very common with them. The abdominal pain will be much more commoner than appendicular pain. Maybe in the range of 5 to 10% will be appendicular. The rest will be gastritis, gastroenteritis, which is so common today. Yeah.
Yeah. Thank you so much, sir.
Sure.
So there's another question from Dr. Mahmood. Can you elaborate on traumatic abdomen with splenic rupture?
Traumatic abdomen with splenic rupture, that patient should come to the hospital and should be treated conservatively. So by and large, we can treat it conservatively without any problem. They don't need it to be operated unless they are hemodynamically unstable. If they need a lot of blood transfusion to keep them hemodynamically stable, then that patient should be operated. But the operation means by and large it becomes the splenectomy. So today we hardly do splenectomy. Most of the time we can manage it conservatively. Yeah.
Right. So some people are saying it's a very nice and elusive presentation, very well taken. So they're congratulating you.
Sir, I wanted to ask one question.
Yeah.
So can I? Thank you,
Yeah,
sir, for the
please.
session. It was really informative. Sir, is there any specific cause? Because most of the diagnosis that we have come is more on the right side of the abdomen. So if there is a pain on the left side of the abdomen, especially in the night, so what does it actually says? I mean, anything related to the pancreas or anything related to the intestines?
Left side abdominal pains may be because of amoebic in origin, particularly if it is left lower abdomen. If it is upper abdomen, then one has to remember pancreatitis or pyelonephritis if it is the upper abdomen. And then it can be because of anything, small bowel or anywhere else, anything.
So investigations has to be ruled out because the pain can look as if it is colicky pain as well.
Yeah, if it is colicky pain, then I will go with the ureteric or kidney stone more likely. Small bowel pain in left side of the abdomen is unlikely because it starts with the midline umbilical area first and then it will get localized.
Sure,
so if it is left side abdominal pain, then maybe one has to think about renal colic.
Okay. Okay.
Yeah.
Thank you, sir.
So there is one question, worm infection causing intestinal obstruction and so 1 second, and obstructive jaundice.
Yeah, so worm infestation, I think, is very common cause of abdominal pain, and it is medical cause, so I have not covered that. But one has to remember any abdominal pain should be treated, particularly if it is not surgical, means there is no guarding rigidity associated with the pain. Treat it with as if the child has worms. That is a primary treatment. So any child who comes in your clinic with abdominal pain, he or she has to be dewormed. There is no doubt about that. As far as the obstructive jaundice is concerned, we did speak about cholangitis. Now, cholangitis is basically obstructive jaundice. So any obstructive jaundice will present with cholangitis. It means there is a jaundice along with the fever and pain. And of course, the reasons, one of the condition which I said was choledochal cyst, because that is what we see in children. But any other cause of obstruction to the bile duct, like with the stone, also can give rise to pain. So if there is choledochal, if there are gallstones with the stone which is slipping into the common bile duct, can give rise to similar obstructive jaundice, though not common in children. Maybe in last 22 years, I have seen maybe 5 to 7 patients who came with stone in the common bile duct needing something and then cholecystectomy.
Right,
Yeah.
sir. Any other questions anybody would like to ask?
Yeah, I think we can go to the next presentation.
Sure. I think, yeah, we are well
Yeah,
time.
thank you.
So,
Thank you for the
Thank you so much.
yeah.
And I would like to invite Dr. Avi Shah, who's my partner, to call for our next speaker, Dr. Bipin. Dr. Avi, are you there?
Yeah. Hi, Shruti. Hopefully, I am audible. So,
Yes.
again, good afternoon, everyone, and thank you for joining in. And I'm Dr. Avisha, one of the pediatric orthopedic consultants, and it's a privilege to introduce one of my colleagues, Dr. Bipin Gangadey. He is a pediatric hand and microsurgeon, and he has extensively trained all over the world, and also has a European diploma in hand surgery from Belgium. He has also done fellowships in Japan and has more than 10 years of experience in hand surgeries. And he has managed many complicated hand procedures. And his special interest is in the topic which he will be speaking today on congenital hand and their reconstruction. So I'd like to invite Bipin to give his talk on congenital anomalies in hand.
Thank you, Dr. Avi, for this introduction. So with excellent presentation by Dr. Rasik Shah, I will just give you an overview of the problems when children are born with congenital hand deformities and a brief about their management. So I'll share my screen now. Okay. So normally the congenital hand anomalies occur between 4 to 8 weeks of gestation. So the 4 to 8 weeks of gestation are very important during the pregnancy. So it has been classified into multiple types. These are the types of classification by Swanson. Swanson was the person who classified congenital hand deformities. So it includes failure of formation, and that means the parts are not formed. A failure of differentiation of parts, as in syndactyly, that means the parts are not differentiated and they're stuck to each other. There can be extra digits or extra phalanges like in duplication. There can be overgrowth as in macrodactyly. There can be undergrowth as in absence of phalanx or absence of a digit. There can be constriction bands. Now these are multiple bands which are, this is not, this cannot be considered a congenital anomaly. However, it occurs during the intrauterine period, and I'll show you in my further slide how to treat this type of anomaly. And then there are generalized skeletal abnormalities. So any baby which is born or which is suspected with congenital malformations have to undergo these tests. The most important test here is radiographs. Obviously, the radiographs play a very important role to find out what type of deformity it is. Then a 2D echo of the heart to rule out if there is any congenital anomaly, because most of the patients with congenital hand anomalies or congenital leg anomalies can present with a congenital heart disease. And if that is so, the heart is a main structure which has to be treated first than the hand. Hand can be treated later on as well. So a 2D echo of the heart is very important here. A sonography of the abdomen. Now, abdomen sonographies are very important as these patients have multiple syndromes like Vactor syndrome, and there can be esophageal atresia, or there can be any other problem in the lower bowel. Then peripheral counts have to be done to rule out thrombocytopenia and other types of Fanconi's anemia. So these are some common type of congenital anomalies which I'm going to discuss today. One of which, the most common of which, is a syndactyly. Syndactyly, as in the two digits are joined together. The two of them can be joined, or the four of them can be joined. We'll discuss this later. The second one of the most common anomaly is a forearm deformity, which is a radial club hand. So this is a type of anomaly in which the radius is absent here, and it has led to this type of deformity. That means the wrist is deviated on the radial side, as in a club, like a golf club. So it is called as a radial club hand. The third type of one of the common deformities is camptodactyly. Camptodactyly is congenital flexion contracture of the finger. So these are the babies who are born with congenital flexion contracture of of the finger. These babies normally don't present very early, and parents only notice when the babies start using their hand significantly. So in this type of deformities, everything is normal, but the babies cannot extend their fingers. Cleft hand, this is a type of deformity in which the central structures are absent, as you can see here. And this leads to a cleft hand type of deformity. Macrodactyly. Macrodactyly is a very bad and a very disgusting looking deformity for a child. So this is a 1-year-old child with this type of deformity, and this has to be treated between 6 to 1 year of age. So these are the constriction ring syndrome that I told. These are amniotic bands. As you can see, this is a 1-day-old baby in which I'm removing an amniotic band. And however, the amniotic bands have already caused constriction and lymphedema in the limbs. They can cause amputation of the fingertips, as you can see here. So babies are born with amputated fingertips and rings around their fingers. It can lead to this type of deformity as well. This is a big lymphedema. This is a leg basically. It has a big lymph, like a big deformity and a pseudoarthrosis of the tibia, and due to the fracture of the tibia. These are all due to these small amniotic bands in the during pregnancy. So now we will discuss all in parts. So this is the most common type of deformity is syndactyly. The type of syndactylies are simple, complex. Simple syndactyly as in there is no bony connection in between them. Only there is a soft tissue connection. These are complex type of syndactylies. Complex syndactylies are the syndactylies where there is a bony connection. So X-rays have to be taken to rule out if there is a bony connection or not a bony connection. These are the Appert. We call it as a rosebud hand. So I'll show you how the Appert hand. This is a Appert syndrome is a syndrome which has craniofacial anomalies as well. So hand is treated only after the craniofacial problems are treated. Acrosyndactyly. Acrosyndactyly is a type of syndactyly which is mostly due to the constriction band syndrome. So now you can see here that there are multiple holes in the finger and the distal part of the fingers are amputated. These are due to the constriction band. And symbrachydactyly. We'll discuss this in detail. So when to operate these children? These children are normally operated after you rule out the cardiac or the gastrointestinal problems. These children are normally operated between 6 to 2 years of age. So why do we operate it between this age? Because it prevents the flexion deformity due to the abnormal growth of the fingers. It allows better bony growth. And if the thumb is involved, it has to be released first. And it is psychologically to the child and mother and parents, it is better if you release it before 2 years of age. So what is the sequence of release? Sequence of the release is first you have to do the thumb, then the border digit. Now you can see there is a significant difference in the length in ring finger and little finger. Here, so this has led to since this is an older child, this is a 12-year-old child. You can see that the contracture was not released, the syndactyly was not released, and it has led to this type of contracture, and hence it has to be released early. So this is a simple syndactyly. The X-ray shows there is no bony connection, and this is a complex syndactyly which shows a bony connection. The Appert hand, what we discussed earlier, this is a complicated type of syndactyly in which you can see the child has this type of Down's face, and they have multiple craniofacial anomalies. So these children have to be first referred to a neurosurgical unit, and the craniofacial, as the brain develops early, so craniofacial anomalies have to be sorted out, and then we get to do the syndactyly. The idea of doing this type of syndactyly is that the patient should have at least tripod type of grip. So in this type of cases in which all the fingers are involved and there is multiple anomalies and bony structures are also joined together, we try and release only those digits which are functionally helpful for the child. So this is another type of this is a acrosyndactyly is a type of is in the constriction band syndrome only. So what happens is that the constriction band amputate the distal digits and they cause raw areas around the digits and the digits joined together. So in this type of syndactyly, what you can see is that the web spaces are normal. So web spaces are normal. However, the fingertips, you cannot say actually tips, but the distal part of the finger is joined here, and there are multiple bony abnormalities. So your idea is again to give a tripod type of grip to the child. So so we plan to release this area and this area. Symbrachydactyly, these are short web digits. So when you see this type of children, you can see that. So normally every one of us has flexion creases. So a child born without these type of flexion creases, that means there is no joint there. So if there is no joint there, that means the child will be unable to flex the fingers. So as you can see here, there is a joint at the metacarpophalangeal joint area. However, there is no joint at the proximal interphalangeal joint area. If you see the X-ray here, the X-ray shows that the middle phalanges are absent here. So these are symbrachydactyly, short wave digits, where you will find that the middle phalanges are absent or they are shortened and there is no flexion at the interphalangeal joint of the finger. Even in the thumb, there is no flexion crease. So the thumb is also not going to flex. However, releasing this finger, all the 4 digits of the finger helps for child to develop good grip. But the parents have to be counseled that there will be no flexion in the fingers. So there are multiple techniques of release of fingertip. So idea is to make a flap in the web space and make this zigzag type of incision and cover the raw areas on the either side of the finger with a skin graft. So this is one of the techniques in which a syndactyly is released. As you can see, there are multiple zigzag incisions are taken. The dorsal skin forms a flap. So you have to. So what is the end point of the release? An end point of the release is the common digital artery. You can see here the bifurcation of common digital artery. So normally a finger has 2 arteries, one on this side and one on the other side. A common digital artery comes from here and it bifurcates. One goes to the ring finger and the other one goes to the middle finger. Similar is the case in this finger. One will go to the middle finger here and one will go to the index finger here. So you have to be careful while dissecting at the web space, because if in case the syndactyly is adjacent, there are adjacent syndactylies. Like if there is a syndactyly of 3 digits, as in the ring, middle, and index, and by mistake you injure the one of the arteries, the finger will survive. However, you have to note that you will not be able to release the other syndactyly. So you have to be very careful while releasing these fingers. Go to the bifurcation, see the artery, and stop there. You can see that the dorsal flap has formed a web space, and the adjacent areas have been covered by flaps by these zigzag incisions. 2 full thickness skin grafts from the groin have been used to cover the raw areas. So what are the tips? Is the Z incision. You avoid grafts on the volar area. Full thickness grafts are preferred. Both the sides should not be operated at the same time. Yeah, this is another important thing, that if there are adjacent digits, after one finger, one side is operated, you wait for 3 months, because in case by chance there is spasm of the artery, it will recur in that period of time and operate it after 3 months. So this is a short video which shows the syndactyly release. This is the type of marking. You really have to carve the finger out, as in like an artist, because the parents and especially the mother will ask you 100 questions. How is the graft going to look? How is my child going to do functionally? There are multiple questions. So a syndactyly is a surgery in which it has to be the finger has to be carved out. So the marking of the flaps. I'll go through this video fast. Yeah, these are the interdigitating flaps which are raised slowly. you have to be careful that the neurovascular structures are very close on both sides. Making incisions of the volar side of the finger is again important because you have to be careful of the neurovascular bundle on the either sides. So yeah, so this is the bifurcation. After you release up to the bifurcation of the common digital artery. See these two raw areas you see. These two raw areas are covered by full thickness grafts, which are harvested from the groin area. This is immediate post-op. So what happens is that eventually the graft shrinks. I'll show you the result after 3 months. However, the parent should know that the scar is going to remain on the dorsal side because the grafted skin is always going to be different. The color of the grafted skin is always going to be different than the natural skin. However, as the child grows, it covers up. Yeah, so you can see this 3 month post follow up. You can see that still there is some darkening of the grafted area. So that was about syndactyly. So another type of deficiencies are longitudinal deficiencies, and these type of deficiencies lead to this radial club hand and ulnar club hand. So radial club hand, as in the structures on the radial side of the hand are absent, of the forearm and hand, upper limb are absent. Ulnar club hand is the opposite of radial club hand. The ulna is absent. So if you see the classification here, the failure of formation of part, longitudinal deficiencies, radial and ulnar deficiencies. The transverse deficiencies lead to complete, there is complete absence of the wrist or complete absence of the finger. There is complete transverse absence of the finger. So however, radial club hand is the most common wrist deformities in a child. So what is absent is the radius, the radial carpus. The thumb can be absent or it might be hypoplastic. The child, hypoplastic as in the child is unable to use the thumb. There might not be any bones, or there might be bones and there might not be any muscles there. So these type of anomalies are associated with multiple type of, might be associated. So you have to rule out all these syndromes like Holt-Oram syndrome, then Vacteral type of syndromes, and the Fanconi's anemia. So again, you have to the workup is very important: 2D echo, sonography, and blood counts. So there are 4 types of radial club hand classification wise, from mild to severe grade. So mild one, both the bones are present. However, there is mild wrist deformity. Type 2 means the radius is slightly shortened. There is deformity. Type 3 is the proximally the small radius. You can see the radius is very small here. However, the deformity is significant. And complete absence, as in there is absence of the radius. In this case, the thumb also might be absent. So child will be born only with 4 fingers and no thumb, or there will be only hanging thumb there. So mild grade, how it presents. So this is a mild grade. There is only slight wrist deformities here. So you can see the radius in ulna has a slight variation here. However, the child is able to do all the function very well. However, always examine these children, because normally all the activities what we do, if you see your daily activities, you do it in ulnar deviation, like holding a glass, holding a mobile. So a radial deviation is not very good for a child. So you observe a child for 1 year, and if the child 1 year to 1.5 years, if the child is unable to do his activities very well, you need to do tendon transfers to correct this type of deformity. This is grade 2. Again, the radius is shortened here and there is a deformity. Whenever these type of mild deformities are there, don't forget to examine the thumb, as the thumb might be hypoplastic, even if there is a small grade of deformity here. So grade 2 has a mild and a moderate type of deformity in which the radius is significantly shorter. Now you can see here, this is a mild type of grade 2 radial club hand. However, the thumb is hypoplastic. There is nothing in the thumb. There are no muscles also and no bones. So what will be the treatment of 1, 2, 0, 1, 2? So if there is a radial support, you can stretch and do tendon transfers, or you can do extensor carpi radialis to extensor carpi ulnaris transfer only on the extensor side. So these type of tendon transfers can be done. However, stretching also is a very good treatment in type of grade 0 and grade 1. So you have to really observe this child up to 1.5 years to 2 years and check that if the child is using his hand very well. These are severe grades, like this is grade 2 severe, in which the deformity is significant, absent thumb. Grade 3, again there is a short radius here, and there is around 90 degree of deformity, like a club. Grade 4 is complete absence. The thumb is also very hypoplastic and 90 degree of deformity. Now, what do you do for this type of significant angulation? So we need to first to correct the angulation. So angulation is corrected immediately as soon as the baby is born. The stretching should be started. So mother has to be told that every time you take a child to breastfeed, you have to stretch the wrist. So this can be continued up to 1 month. And after 1 month, as the child the skin becomes better, he has to be casted regularly, like weekly casting is needed. And then after that, you need to give a splint. So this splintage has to be continued up to 6 months of age. You should know that this type of children, this type of children, they don't have radius here. So there is always a recurrence of deformity. So to prevent that recurrence, we need to centralize this type of wrist. So initially what we do is we distract. So idea of distraction is same like casting and manipulation. If the child presents early, you might not need to apply a distractor. However, if a child presents at 6 months of age, then the deformity becomes significantly rigid and stiff. It will not come with stretching and casting. So you need to apply what is called as a external fixator. So external fixator is applied and a differential distraction is done to stretch out this deformity. And when the wrist comes over the forearm, you use a bilobe flap technique and centralize the wrist like this. So wrist has to be centralized. So even if after centralization, you still have to remember that there is no radius here. So there has to be either you have to give a radial support, or you have to counsel the parents that the child has to use a splint up to 18 years of age. So this is a study which we had done in which we found out that with this technique, normally the distraction and radialization, we get about around 69% of the length of the opposite side. So normally the length is also a problem in this case. The children have a shorter forearm compared to the other side. So we measured the length and we found out the earlier techniques in which centralization was done, not the radialization, centralization, where the carpus were removed and there was a significant facial injury during the surgery. The lengths were significantly shorter. So lengths were around 30% of the opposite side. But with our technique, we can maintain the length to around 70% of the opposite side. So this is a new procedure. Now, as I said, as I told you that the radius is absent. So this doctor, Dr. Wilkie, Simo Wilkie, what did he do? He took a fibula from the leg and vascularized, like a vascularized fibula, and he grafted it and created a V to support the radial side. So this is another technique which has been reported in literature. So what do you do for thumb? So what do you do the thumb? So every one of us know that thumb is very important for our daily day-to-day life, and for most of the activities are done by the thumb. If you don't have a thumb, then most of your activities are really go down. We know the story of Eklavya, that he didn't have thumb, so he couldn't compete with Arjun. However, what we do now is children who are born without thumb or have such type of hypoplastic thumb, a severe grade. You can see this is a severe type of hypoplastic thumb, as in there is no metacarpal here, and there is very short. The phalanx, the metacarpal is a very small structure here. So these are hypoplastic thumb. That means they don't have any bony support here. So we use the index finger and rotate it to make a thumb. So this procedure is called as polycization. So a baby will have 3 fingers and a thumb. So even if the baby has 3 fingers and a thumb, he is able to do all his activities, because what the most we need is a thumb and 2 fingers to do activities. 3 fingers is an advantage. So 3 fingers and a thumb is a great thing for the child. So this is a child who has been operated with polycization. He was operated at with multiple radial. He had radial club and bilateral hypoplastic thumb. So we operated this child at 1 year after the radial procedures were done on both sides. So you can see the left side now, and he is significantly using his thumb. This 6 months after the operation. So these thumbs have to be created before 18 months of age, as the brain center for thumb develops after 2 years of age. So we try and do the thumbs before 2 years of age. However, if if there is an older child who doesn't have a thumb and is missed, even then it makes a significant difference in the life of the child. The training required in a child in whom polycization is done early is significantly less than an older child. So this is the same child. Now both the thumbs are done here. So the life of a child is completely changed. You can see that he's the same child, and yeah, he's lifting with other hand. He's writing. See, you can see he's using this type of. 1 minute. Yeah, you can see. Yeah, you can see the child is trying to hold it between his ring and little finger. So this is the type of grip you need to avoid. So this type of grip develops only in older children. So you have to train these children to use their thumbs. So children who are not who are born without thumb will use this scissor type of grip. You can see, however, the child is since the left thumb was created before the right thumb, he started to write with the left hand before the right hand.
6 बजे का दिया है टाइम में 20-25 का.
So polycization is a very old operation, and it has been described by a German scientist, Buck Gramko, and it has significantly changed the lives of children who are born without thumb. So this is now ulnar club hand is this is the opposite side of radial club hand. So in radial club hand, the radius is absent. In ulnar club hand, the deformity is reverse. There is a ulnar deviation and the ulna is absent. So like here, the ulna is absent and the deformity is ulna. So what do you do in this case? You have to see how functional the child is. You have to rule out these craniofacial anomalies like the proximal femoral focal deficiencies, fibular deficiencies, scoliosis, or any internal anomaly. So all children have to be ruled out. All children with congenital anomalies have to be ruled out with other problems. So idea in ulnar club hand is to improve the hand function. It is not to correct the deformity, but to improve the hand function. So you can do it because in this case the thumb is present. Remember, in ulnar club hand, most of the ulnar club hand has a thumbs are present because it is an ulnar side problem. However, some children might have absent thumb also. So web deepening or for thumb, you can do opponentsplasty and polycization again. So this is a child ulnar club hand, the same child in which the ulna was absent, and the deformity was on the ulnar side. However, there were absent thumb. So we created the thumb and he improved significantly well. So for radial club hand, if there is a presence of radial support, stretching and radial transfers can be done. And if there is no radius, or radius is significantly short, then distraction and radialization are the procedure of choice. And obviously, there can be recurrence of these deformities because the one side of the bone is absent, and these have to be corrected by multiple surgeries again. But the important thing here is, if the thumb is absent, you make a thumb in both the type of deformities. So now we come to our next deformity. Next common deformity is a camptodactyly. So camptodactyly is a painless flexion contracture of the proximal interphalangeal joint. So it is painless. This is a 13-year-old girl. She's still using her finger and hand very well. However, what happens is this finger becomes, first thing is that the patient presents for a cosmetic problem. They only present for a cosmetic problem initially. So do you need to treat this type of deformity is a question. Yeah. So we'll answer this question in this. So it has unknown etiology, and there are only multiple contractures of skin, fascia, and there will be imbalance in the flexion and extension forces. There can be abnormal structures like abnormal lumbrical, or it can be, most common is the little finger. So this is a simple type. Yeah, you can see here there is a simple type of flexion contracture. So not all camptodactylies need treatment. If the flexion deformity is around 30 degrees, just leave it. Tell the parents to only do stretching. So around 30 degrees of flexion deformity, they do not need treatment. If the deformity progresses around 90 to 120 degrees, those are the babies which need treatment. What happens is that when these flex type of fingers become very prone to injuries, they get caught in doors because the proprioception is lost and they don't move with other fingers. So that is the main indication. If the deformity is more than 90 degrees, then only you operate camptodactyly, because the recurrence in a camptodactyly is really very high. And parents should be warned that there will be very high recurrence in case of camptodactyly. So these are complex camptodactyly. Now this is a patient with a radial club hand, and he had this camptodactylous finger. We have polycized this finger, and he's still using the thumb very well. These are very complex type of deformities. So there can be associated anomalies also, like radial club hand and camptodactyly. They go hand in hand. So what happens now? This is the X-ray of the same child which you saw initially. What happens is that as you take an X-ray in an older child, you see this classical parrot beaking appearance in a severe camptodactyly. This has been published in 2015. So mainly, as I told you, the main concern is a cosmetic concern. Functional problem, difficulty in opening the finger for a grasp, and functional problem also can be there when other fingers are involved. So as I told you, when the deformity is less than 30 to 40 degrees, just counseling and stretching. Family counseling is very important, because most of the patients with camptodactyly are females, and the parents think about that what will happen to the girl when she goes to when she goes for a marriage. So, but you have to counsel the parent that 30 to 40 degrees of deformity is not going to make a difference in the child's life, and it is not going to cause any problem in her function. So you have to accept the deformity, avoid surgery. Static splints and stretching can be given to prevent progression. So again, stretching is the mainstay of treatment. Stretching followed by static splints or serial cast can be done. So aim of the treatment is to reduce the deformities, because even if you operate, the deformity is going to go around to 30 degrees. This is because it is not only the soft tissues which are tight, like the tendons and the skin. The neurovascular bundle is also tight. So if you try to stretch it more, there can be a chance that there can be a neurovascular problem, and the you might lose the finger. So during surgery also don't overcorrect the deformity. If you try to overcorrect the deformity, you might break the neurovascular bundle, and in the process the child might lose the finger. So surgery is done only when the conservative treatment fails. So this is a type of infantile camptodactyly which we saw in a NICU, and you can see when the child is, after continuous stretching, parents have been told to stretch. She has got significant extension of the fingers. So again there is another child in whom there is a radial club hand, and significant stretching has been done. The radial club hand is also associated with camptodactyly. So you have to rule out other syndrome. So these children are syndromic children don't do very good in terms of treatment for both radial club hand and for camptodactyly. So it can be associated with other anomalies and contracture of other joint, like in arthrogryposis also. So what if the deformity progresses? So if the moderate deformity, if it is going more than 30 degrees and severe deformity is more than 60 degrees, start with conservative and splinting initially. And if there is more significant deformity, then you need to operate. However, you have to warn for recurrence. So what is to be done in the surgical treatment is you have to go volarly. You have to do tenotomy of the flexor digitorum superficialis. There can be abnormal structures like the lumbricals, which cause flexion contracture. They have to be excised. Tendon transfers can be done, like flexor to extensors. Joint arthrolysis in a very significant contracture has been done. So we have to remember this, that we have to achieve correction, but do not stretch the neurovascular bundle. Hence, undercorrect the deformity. You don't have to make it straight on table. Keep it flexed to 30 degrees. So 90 degrees can be brought to 30 degrees and tell the parents, isse zyada seedha hone nahi wala. Finger defect should be covered. If there is a defect in the finger, it can be covered with a flap or a full thickness graft. So this is type of, you can see here the flexor FDS is very tight, and the FDS. So there are two tendons normally in a finger, the FDS and FDP. The problem is with the FDS, lumbrical is attached to the, instead of FDP, it is attached to the FDS here, which is abnormal. You need to excise the abnormal lumbrical, and you need to do tenotomy of this tendon. So even if you do tenotomy of the tendon, the FDP will cause flexion of the finger. So you get a significantly good correction here. And at 3-year follow-up, the baby, you can see still there is some flexion deformity, and parents have to be told that the flexion deformity will remain. Moderate type of deformity, the FDS is tight, you correct, palmar plate is released, and after complete release, this is another type of in which now after release on the volar side, we went on the dorsal side, and the attenuation of the central sleeve, like the extensor tendon is shortened here to maintain the extension. Never use, we never use a K-wire to fix this position, because, as I told you, under correction is better than over correction. Inserting a K-wire might stretch the neurovascular bundle, and we might lose the finger. This is the correction. So arthrogrypotic complex camptodactyly, full thickness skin graft, if at all used, it is used in the palm area. So recurrence, if there is a recurrence, you need to do stretching and re-release. Recurrence is very bad. So this is a 11-year-old child. So this child didn't have any problem till up to 11 years. However, as I told you, that this finger is very prone to injury. So the finger might be caught in a door because it doesn't go along with the other fingers. So what we did is we released it, but however, there was a significant defect here, and we covered it with a cross finger flap. Cross finger flap is a flap, we take it from the other finger. You have to keep the two fingers joined, and this is the flap from the dorsal side. This finger, these two fingers are kept joined for around 2 weeks, and you divide the flap later on. At that follow-up, you get significant straightening of the finger. The child, the parents are very happy here. So what works in camptodactyly is stretching splint. Mild camptodactyly, only reassurance and splint. Moderate camptodactyly, do multiple Z-plasties, palmar plate release, and FDS stenotomy. Severe, you can do a skin release or a cross finger flap to cover the raw area. So these are the what we do in a constriction band. So if there is a significant band around the forearm here, you can see that the constriction band has auto amputated the fingertips, and this patient presented at around 1 year with this type of band, circumferential band. The other side, we always do a hemi release. We don't do a 360 release at one time, because again, there might not be any neurovascular structures here, that the radius, the band is so tight that the radial artery might be cut and the hand is surviving only on collaterals. So after you release the other side, you have to release the other hemi part only after 3 months, so that the collaterals are formed here. So these are multiple Z-plasty. You release the band and stretch the wrist. Cleft hand is another type of deformity which I showed you in the beginning. So cleft closure, this is a very rewarding surgery for cosmetically and functionally. Again, the fingers are rotated here, and after cleft closure, you have to really take care that the fingers are not rotated and put a flap in a proper way so that the cleft is closed. So these are congenital problems which we discussed. So these are normally during birth or in the when the child during gestation or during birth. So I will also like to discuss about pediatric brachial plexus palsies, which are the injuries. This is basically not a congenital anomaly. However, these are brachial plexus injuries. The child is born with a flail limb. They are unable to move the upper limb here as the child is born, and the pediatrician tells that the child is unable to move the upper limb, and we get a call. So these are normally intrauterine injuries during delivery, which happen mostly during vaginal delivery. However, cesarean section can also cause to this, can lead to these problems. So this is a schematic representation of a brachial plexus, we know. So they have C5, C6, C7, C8, T1, this type of roots, and multiple trunks. Upper, middle, and lower trunk, and then there are cords, lateral, posterior, and middle cord. So injury to a portion of this type to these nerves during delivery can lead to paralysis in a child. So it can be preganglionic and postganglionic, supraclavicular as in above clavicle and below clavicle. And it can be a nature of injury, as in it can be total, all roots are injured or only partial injury. So what are the risk factors? A big baby is a major risk factor. If the baby is very big, then the chances of getting pediatric brachial plexus palsies are very high. Breech presentation, shoulder dystocia is another common cause of because to save the child's or mother's life, the obstetrician tries to pull the baby or apply suction in a significant period of time, and in that period there might be an injury due to traction. Prolonged labor and other congenital problems can also lead to this type of injury. So upper plexus injuries are normally 60% C5, C6 injuries. Lower plexus are very less. These children are associated with Horner's syndrome. I'll show you what is Horner's syndrome. So this is a child which looks, this is a around 2 months old child which has a pediatric brachial plexus palsy. You can see that the child has a internally rotated shoulder and flexed wrist and like a policeman tips position. So this is and there is also significant sensory loss. So waiters, like this is the type of position which the children develop, is the waiters position or policeman tips position. So there can be multiple muscle weaknesses like external rotator, abductor, flexors, extensors, and diaphragm. There can be diaphragmatic paralysis also. Risk factors are maternal, fetal, intrapartum events like prolonged labor or any other problem, and neonatal also. So mechanism of injury, as I told you, it is mostly, so what we see is mainly shoulder dystocia, so that there is a stretch and there can be injury. So Horner syndrome is brachial plexus palsies in children can be associated with Horner syndrome, injury to cervical sympathetic ganglia, in which the child has a small eye. So brachial plexus paralysis with a small eye is Horner syndrome. So he has anophthalmos, ptosis, swelling of the lower lid, miosis, and there is no, there are no tears in the eye. So in global, so what we do in this type of children are we wait up to 3 months, and at 3 months, if there is no recovery, we immediately operate. They can be associated with fracture of the clavicle, humerus, or cervical injury, facial nerve injury, or phrenic nerve palsy. So all the fractures are managed conservatively in this case. Anyways, we have to wait till 3 months till the child is become significantly fit for the surgery, or we have to wait till 3 months so that there is recovery of the nerves. So recovery, what we see at 3 months. So what are the types of injury? There can be avulsion, rupture, stretching. So if there is stretching, as in neuropraxia, that means there is only stretching, nothing is cut. They recover immediately at 3 months of age. In fact, we see recovery early at 2 months only. So you have to do the X-ray, EMG, NCV, and the MRI. CT myelogram also can be done. However, the main investigations are X-ray, EMG, NCV, like electromyography, and the MRI. So if there is no recovery at 3 months of age, we go in and we repair the nerve. So the nerve surgery can be done between 3 months to 1 year of age, because after 1 year of age, the muscles don't receive any electrical stimulation from the nerves, and the nerve surgeries cannot be done. So whatever chance of recovery is between 3 months to 1 year of age. So this is the type of surgery we do. This is a case in which the baby had a C5, C6 injury. So hand was present, but there was no elbow flexion and shoulder abduction. So we look at around 3 months of age. If there is no elbow flexion, we go in and operate and confirm it with nerve conduction studies. If on nerve conduction there is no elbow flexion, again, that is the time to operate. So what we have done here is a spinal accessory nerve is transferred to suprascapular nerve for shoulder, and the ulnar nerve fascicle. One part of ulnar nerve is given to musculocutaneous nerve for elbow flexion. Because the ulnar nerve is a fascicle can be used. This type of transfer is called as a Oberlin transfer, because a neurosurgeon named Oberlin has described this type of procedure. However, if there is a recovery, if the child is recovering, we do not operate. So we wait till 8 to 9 months of age. And if there is, however, the child will not develop a movement immediately. There will be power in the muscle on EMG, NCV, but there won't be any movement sometimes. This is due to muscle contractures. So muscle contractures can be very well treated with injection Botox. Botulinum toxin is a type of injection which is used for spasmodic and contracted muscles. So we give we find out that which muscles are at risk and contracted, and we give the injection. Next procedure which is done is at an older age is a tendon transfer. Again, tendon transfers also can be done. These procedures are only done after there is a recovery in the nerves. So these are the type of shoulder CT scans we do after 1 year of age to check that if there is no shoulder contracture. So this is type of deformity the child developed, like internal rotation. This is the typical trumpet sign. This is an older child who has recovered with brachial plexus nerve injury. So muscles have gained power, but the power is not very power is such that it has led to contractures. So there is a internal rotation contracture of the shoulder, and when you ask the child to put the finger in her mouth, it gives a position like a trumpet. So this is called as a trumpet sign. So you need to release this type of deformities, otherwise they cause a problem, the muscles will cause problem to the bone and it will become a static deformity. So we do tendon transfers and contracture release in such cases. So this is a release from the anterior side, and the teres major and latissimus dorsi is transferred on the external side. So tendon transfers also can be done later on for improving the hand functions. Later on, if there is a problem with the bone, other remaining bony procedures can be done. But these are at a very older age, around 7 to 8 years of age. Thank you. Hello. Yeah, Dr.
Yeah, hi. Thank you, Bipin. That was an excellent overview of all upper limb issues. So if anyone has any questions, if they would like to ask, please do so. There was one question before in the chat box. Is it possible to diagnose Apert syndrome antenatally and kind of be prepared?
So antenatally, yes, it can be diagnosed because Apert syndrome is a kind of syndrome. It has multiple anomalies. See, only hand anomalies is difficult to diagnose.
Yes.
Antenatally in the ultrasound, which the anomaly scan, what they say. So many of these problems are missed antenatally if it is only a hand problem. However, Apert is a craniofacial anomaly also, and it has other multiple factors in it. So Aperts can be diagnosed on with a very good ultrasonologist. Yes.
Yeah. So with modern fetal medicine, it's becoming, I mean, there is a chance of us diagnosing such conditions earlier. Are there any other questions? If anyone would like to ask, you can type it in the chat box or just unmute and ask.
So there is one question which always comes to with the babies, everyone, not for me, maybe for pediatric orthopedic surgeons also. They come antenatally, they have been diagnosed with deformities and they come to you. Yes. And then they ask whether this should be kept or
like what would be the best timing, you would say?
So this is a very important question which comes to all the surgeons. Yeah, so best timing. So I feel that if it is just a single limb problem and not if it is not a syndromic baby, then there is no harm in continuing the baby. So that is what is followed worldwide, because these problems are really treated and they are treated very well. So, but if the baby is syndromic and he has multiple problems, then you have to really see that is the baby going to survive through the pregnancy. Yes.
Yeah. So that's a discussion for parents and the physician at the time.
Yes.
Because these children do require a lot of surgeries at times, and a lot of other things might be a part of their care. The other thing, till someone asks, so like for most of these congenital anomalies, like some of them are sent directly at birth because most of these are evident. These are not hidden conditions. So like from your expertise, what is the best timing for you to start surgery? Is it as soon as they come, or do you wait, and what is your best time?
So it depends. So that's a surgery. The problem, like the constriction band, I have showed you one picture in which I am removing the band.
Yes.
So if the baby presents to you immediately in the NICU, you take the baby inside and try and remove that band, because that band is going to go deeper eventually.
Yes.
So, however, conditions like syndactyly can wait. There are other conditions which can really wait. So another thing about constriction band, there are bands, they present with neurovascular problems also. So those are emergencies and you need to really release the band, and so that the hand is saved. So not all congenital anomalies really need immediate intervention. They can really wait. We can wait up to 3 months until the child is over 3 months of age or 6 months of age, and he becomes really fit for that surgery. However, we can correct them later on also.
So ideally, would you say like we would prefer, I would not say cutoff, but prefer to do whatever possible before age 2, something so that we can give
before age 2, correct. Upper limb, because most of the brain centers of upper limb develop during that time. So if you give a child a chance to use that part early, then the center will also develop likewise. So I think before 18 months is the ideal time to do anything, any stuff. And after 6 months.
6 months. So from 6 months to 18 months, you would say is the ideal period where we can start planning these
Planning, yeah.
procedures. And if
parents are not very, they're not convinced immediately. We need to counsel them also. This takes time. So
Yes.
if the child is presents to us early, we can tell them, "Nahi, abhi rukenge, wait." Then they see other children who have done well.
Yes.
They are really ready for the stuff. Otherwise, immediately, if someone tells you, if they don't come and they are late, then they really miss the bus. Because the problem, like basically a hypoplastic thumb, I have seen children who are 12 years of age without thumb. They are using their hand, but not to that extent which they would have used if there was a thumb. It is not that they are not using it, but they are not using it to that extent.
Yeah.
So that is what I want to say. It is going to make a difference in the child's lifestyle, and there are multiple things the child will tell you as he grows.
So there's a question that they have asked. I think you have answered most of it. Like, when should you intervene if the anomalies present after 6 months in a child that are not presented before? So as you have already said, that if they have presented late, but you need to still go through the entire system of examination as you described, of ruling out all the syndromes and the investigations, and then start the treatment.
So first thing is cardiac, because most of the hand, the bud is same, heart and hand. They have the same bud from which they originate. So many of the children with cardiac anomalies, with heart problems can have cardiac anomalies. With hand problems can have cardiac anomalies, and vice versa. So you really have to rule out cardiac problem. If they have a cardiac problem, that is a priority, because we can really treat them after. It is not going to make a difference in it is not a life-saving procedure, as I said.
Yes.
But a cardiac surgery is a life-saving procedure. So you need to. Another thing is about the craniofacial thing, what I told. So upper fingers we released after the craniofacial anomalies have been sorted out. So that is the priority. So normally a craniofacial surgeon will operate the child at around 8 to 1 year of age with neurosurgery help. And then after that, these children really come to us at around 18 months to 2 years.
All right. So there's another question from Hiren. So he's Dr. Hiren Panwala is our radiologist. So he's asking, is there any role of the of MRI scan basically in anomalies such as these longitudinal deficiencies like our ulnar and radial deficiencies to look for absent muscles, tendons, and anatomy? Is there a role of MRI scan for these kind of children? Do you prefer to get them done?
No. So basically, so we don't do an MRI scan. We do a sonography, and even if their baby has a radial club hand, it has been diagnosed by a radiologist and it has been proved. They come to us asking that whether this has to be really preserved. So our answer to this is that if there are no multiple anomalies, syndromes, we can really give a baby now we have a patient who is a doctor now in the US, who has been radialized and then polycized. So it is not that they cannot do live a normal lifestyle. Only thing is that you have to rule out other anomalies. So if there are other anomalies are absent, you can really treat this deformity.
And the last question, Dr. Tejal asked, like most of these conditions, do they have any associated family history, like of any of these anomalies?
Yeah. So what we have seen that there might not be an associated family history. However, we tend to do genetic workup of all the family genetic workup to check whether, because many of the parents, they come, if it is a first child, they ask whether the second child is also going to get the deformity. That is another significant question that comes. So the other child might not get.
Yeah.
So we do a chromosomal analysis of these children also.
Okay. Excellent. Thank you so much, Bipin, for a wonderful talk. I think it's time. Let me just check if our next speaker, Dr. Taral, is here. If sir is here. Till then, so sir has just arrived. So
Okay.
I'd just like to introduce our next speaker. I mean, Dr. Taral sir definitely doesn't need much of introduction to anyone. He is one of the most prominent pediatric orthopedic surgeons, not just in India, in Bombay and India. He is a mentor to most of us in the department in pediatric orthopedics at SRCC Children's Hospital. And sir has a vast experience in not just in managing, diagnosing and treating pediatric orthopedic conditions. He is also part of extensive societies and foundations, and does helps a lot of patients who are in need. And sir is the backbone of our pediatric orthopedic department. So it's my privilege to honor Dr. Taral Nagda. And sir is going to be speaking from his experience on the hits and misses that he has seen in pediatric orthopedics in his lifetime journey. Sir, if you could, yeah.
Thanks, Avi. I was patiently listening to both the talks. So I have not arrived just now. I have been also listening. And so it's a very pertinent topic, hits and misses. Okay, if you miss your wife's birthday, you get hit. And then that's an example of what not to miss in life. And the whole life is about experiences and mistakes. The mistakes, if you learn from, then it becomes an experience. If you don't learn from your mistakes, then it becomes stupidity. And this is what this talk is about. It is, for all physicians, pediatricians, residents, this will be useful, I feel. And I welcome everybody, and I would like everyone to participate in this talk, and that will make it very interesting. So, in the life, the question is, should we be late, or, should never arrive at, the destination? So, I want to learn from all participants. What is better? Is being late better, or, to have never gone to a doctor better in your life? So just type in your chat box, if it's available, what is better? Late is better or never is better?
Better late.
Better, yeah. So any Avi, what do you think? This happens. I know Avi probably liked a girl and never proposed to her. So did you propose late or never propose to her? What is better?
No, it was late.
It was late. Okay. So these are dilemmas in life, and it happens. And there is a proverb which says, "A stitch in time saves 9." And it's all about diagnosing a case early and acting upon the management early. And we are going to go through some of the pediatric orthopedic conditions and see how this applies to day-to-day life. So I'm Dr. Taral Nagda. I've been introduced as pediatric orthopedic surgeon at SRCC NH Children's Hospital. And I remember when I was taking a talk once for some of the general practitioners at Worli, I was introduced saying that sir is world famous in Worli. So that's how we get introduced. But thanks, Avi, for the kind introduction. And for Avi and me, what I would like to say on behalf of even Bipin and all of us, that orthopedics in children should be treated by specialists, because children are not half adults. We know that a half dose of medicine is not pediatric dose. You have to calculate per kilo dose. Another reason is children's conditions, they are not picked up on X-rays because most of their bones are not seen on the X-ray. We need ultrasound, we need MRI, other imagings to diagnose their conditions. And the most important thing is you will see that anything to do with children, and that applies also to pediatric orthopedic surgeons, we are very friendly with children and the parents as well. So that's the whole spectrum of pediatric orthopedics. You see spinal deformities on top, and then second row shows cerebral palsy. We also deal with deformities which are birth defects or post-traumatic deformities or post-infective deformities, and they correct them. We also correct limb length discrepancies. So that's the spectrum of work we deal with as a pediatric orthopedic surgeon. We're not going to cover the whole spectrum, but few cases, which I'm going to discuss. So this is a 1-year-old child with foot deformity, and something which is very commonly seen. And I would like people to write in chat if they can identify this deformity. What is the name of this deformity? Let's people can type, and let's see what are the answers they come up with. many names to this problem, something which is very obvious. Dr. Vinay Desai is very rightly said it's clubfoot in common language. Yeah, Dr. Kshama is saying CTV. Cubitus varus is not the right answer. No. Cubitus varus is in the elbow. So Dr. Shruti, this is not cubitus varus. Yeah. So this is a clubfoot or CTV, congenital talipes equinovarus. CTV, congenital means from birth. Talus and pes means it's ankle and foot. And varus is the nature of deformity. Clubfoot because it looks like stick of a golf, and that's why we call it a. Okay, so why it is necessary to now detect this in time? If detected well in time, it is possible to treat clubfoot completely without any anesthesia, without any admissions in the hospital. I remember when I was a resident, we used to do a surgery called postomedial release, a big surgery, big incision, anesthesia, change of plasters for these patients. The treatment has completely changed now today. The treatment today consists of serial plasters. So if parents ask what is the treatment now, it consists of plasters without anesthesia and a small percutaneous procedure called tenotomy, which we use using a needle. Okay, so that's the treatment. When the child is born and this deformity is seen, what we tell the parents is massage the foot. We'll see the child when the child is 1 week old or 1 month old. And people used to say earlier that the child will need plaster under anesthesia, but this is not true any longer. The treatment is Ponseti's method, as I said, and it consists of serial plasters, not started immediately after birth. It's not that there is a breech delivery and as soon as the feet deliver, you have to start plastering. But around, once the child is discharged back home, around 1 week is the time when we start the plasters. No anesthesia is needed. He may need a tenotomy at end of 3 or 4 plasters, and child will need to use splint for 3 months full time, and at night for 3 years. This is something which is important. So if you know that a child has been treated for clubfoot by Dr. Avi or me or somebody at SRCC Children's Hospital, and child has come to you for follow-up, you must ask the child, are you still wearing the splint? Because use of splints and the compliance with splint is directly related to the results which we get. So, you have this child, she was detected through an intrauterine scan to be having clubfoot. We don't start the treatment intrauterine. There is no way you can massage the foot in the utero, or there is way to do plasters in utero. You don't start the treatment there, but you start the treatment around 1 week after the surgery. This is how the treatment is done. You do plasters, 1st week, 2nd week, 3rd week, 4th week, 5th week. With the plasters, the front part of the foot is corrected. Equinus, it stays behind, and then that is corrected by doing tenotomy under local anesthesia. And this is how you see the child using the brace, turning around, and this is how this child's feet are completely corrected. This is at around 3 months age. So this girl, today she is doing dancing, gymnastics, and is able to do everything which a normal child is doing. So the message to the parents from a general practitioner or a pediatrician should be that this deformity is compatible with 100% normal life. If this is detected on an ultrasound, there is no need to go for termination of pregnancy, because there is no deformity or impairment or disability which is associated with clubfoot. Children will have completely normal foot, and they will be able to take part in dance, running, all adventure activities, and there is no disability at all. Okay. And then when you get an email like this sometimes, or a WhatsApp message that my wife is 6 months pregnant, ultrasound shows that there is bilateral clubfoot, how soon should we start treatment? So of course, stitch in time saves 9, but that stitch or a treatment has to begin around 1 week from the time of birth. Doesn't have to be intrauterine or immediately after birth. Okay, so that's about clubfoot. Any questions on clubfoot? You can put it on chat. Otherwise, I'm going to proceed to the next topic, which is CDH. CDH means congenital dislocation of hip. To Rasik, this may mean congenital diaphragmatic hernia, but to orthopedic surgeon, this is congenital dislocation of hip. Now we don't call it as CDH, we call it as DDH or developmental hip dysplasia, because now we know that it's not necessary that the child will have dislocation at birth. It can come up anytime during first first 4 months of life. So this is a child which was referred to us as SRC children. She would change the diapers. So when there is a symptom, we need to address the symptom, and it is necessary to address the symptoms because clubfoot is something which is obvious. The where the child is born, the ayabai of that maternity home also will tell you that the child has clubfoot. However, DDH is subtle. It needs to be screened for. It needs to be looked for. And there are certain tests which are required to be done to know if the child has DDH for hip screening. So you'll ask, was this a firstborn child? If this is a female child, if this is a breech delivery, if there is LSCS history, if there is a history of DDH or a hip problem in family, then these are the children which they are at risk. They are more likely to have DDH. You look at the child as a whole. If the child has torticollis or a flatness of face or a knee which is completely straight. Normally children have knee which is little bent and they straighten by 3 months age, but if the knee is completely straight, it may be an indication of CDH. Metatarsal adductors, which is curviness of the foot or a club foot, then these are again high risks for DDH. So DDH doesn't show very prominently, but if the child has any of these issues, it may mean that child may also have DDH. Okay, so these are at-risk signs. You must look at the child inguinal folds and the anal folds. So if the thigh folds are unequal, but if thigh folds are symmetrical, it may mean the child either has no DDH or has bilateral DDH. That's why we rely on inguinal folds. And inguinal folds, if they normally don't cross the anal opening, but if they cross anal opening on one side, then it is unilateral DDH. But as in this case, the inguinal folds were crossing on both sides, then it means bilateral DDH. These are some of the signs. If there is unilateral DDH, one means that lower than the other. This is Galeazzi's sign, but it will be normal in a bilateral DDH. Now, this is something you should learn about Ortolani's test. Ortolani was an Austrian pediatrician, and he had a mother who said that the child is having click every time I change the diaper, and he found out that child actually had DDH. So he found out this test, and I'm going to play video of this test. To stabilize the pelvis with one hand, and with other hand, gradually, gently, abduct, and you see that clunk of entry. So when Ortolani's test is positive, it means the hip is dislocated, and by abducting the hip, you are relocating. And when you relocate, you hear the clunk. Barlow was Ortolani's student, and he was even smarter, and he could demonstrate a test in which hips which were not dislocated, but they were dislocatable or unstable, could also be picked up. And this is Barlow's test. You again stabilize the pelvis and push the knee backwards. And hip is, if it's unstable, the hip will dislocate and you'll have clunk of exit. And don't forget to do Ortolani test after Barlow test, otherwise the hip will remain outside. So after doing Barlow's test, you're supposed to abduct the hip so that the hip goes inside. So whether the clinical tests are positive or high risk factors are present, these hips should be subjected to a pediatric orthopedic opinion and also an ultrasound. Why? Because X-rays cannot pick up hip dislocation because femoral head is not ossified. What will pick up a hip dislocation is an ultrasound. And the treatment now is very simple. This is a polyc harness. It's a 1,000 rupee harness, which allows the mother to feed the child, to clean the diapers, make him wear the diapers, and yet can treat a hip which is dislocated very simply. So that is what the polyc harness looks like. So to give you an example, a child who is 30-day-old, X-rays which were done for shortening, but they don't show much. An ultrasound picked up the hip dislocation, and then this child was treated with polyc harness for 2 months. And at the end of the treatment, both the hips, as shown by ultrasound, were normal, and the child ultimately did very well without any surgery. But if you miss the diagnosis, child comes at 8 months, and now the mother has felt that there is something wrong. All of you can, feel that there is something wrong here on the right side. The right leg is shorter, and if this happens, then you do this Galeazzi test. You notice that the hip abduction is restricted on the right side, and then you do an X-ray, and you see that there is something wrong with the right hip, and probably there is dislocation. So the best treatment at that time is to do an arthrogram. This is how we do an arthrogram under anesthesia. See the heads of the femur because it's not visible on the X-ray, and then close reduce the hip and put the child in a spica. So from a treatment of Paulic harness at 3 months, when the child comes at 8 months, you come to a treatment where plaster needs to be given under anesthesia. Child needs to be admitted. So it is a little more complex treatment. If the child doesn't come within 1 year and comes later on, you need to do more. So this is a 3-year-old child and has limb shortening and has hip dislocation on one side. Here, Paulic harness will not work. The spica will not work. This child requires a major surgery, which involves open reduction of hip, a femoral osteotomy, something on the acetabular side. So 5 to 6 hours of surgery, 2 to 3 days of admission, and 2 to 3 months of spica and immobilization if you treat at 3 years. So it's important to realize here a stitching time saves not just 9 or 10, which is possible. And that's why at SRCC we have this CHIPS program, the Congenital Hip Screening Program. And if you have any of these high-risk children, send to SRCC for a clinical evaluation. And ultrasound so that we can diagnose and treat as early as possible deformities and developmental problems which don't need treatment. So genu varum in an 80-month-old child or genu valgum in a 3-year-old child could be normal, and you really don't need to treat. This is physiological and will correct with time. But if the child comes late, a varus which comes at 5 years, or if you have genu valgum comes at around 10 years, that needs to be treated. And the treatment, if once the child comes late, is correction. So this is a child who came at 13-year-old where the physis was closed. So this child cannot be treated with brace, cannot be treated with massages. What really requires is surgery for these children who are older. So when children come after the physis is closed, they require a corrective osteotomy. We managed to do percutaneously sometime in this manner. And with minimum scar we can correct the deformity, and child will miss school, miss sports, and there is an easier way to correct this deformity. If a child comes on time, before there is skeletal maturity, then we can treat these deformities by controlling the growth. So this is a 10-year-old child with genu valgum, and in this child we could correct the deformity by using this plates to control the growth. We put plates on the medial side in lower femur and upper tibia. In over a period of 9 months, because the growth continues on the outer side, this deformity will gradually correct it. So it's a daycare surgery. We don't need any immobilization. Child can go to school after a couple of weeks. And this is how, over a period of time, this deformity will be completely corrected using these plates. And this child can walk now normally. There is another sort of now development over the plates. We don't use plates now, but whenever possible, we use these screws to correct genu valgum. Because this surgery can be done through a single stitch. The child can walk the next day and join in sports in around 3 to 4 days time. The child can dance, jog, travel, do as early as possible. And this is how the deformity can be corrected using this method. And this is a cosmetic method with early return to function and faster correction. Okay. So the issue is these are all theoretical solutions, but it's important, that those solutions have to be available to the patient. So can anyone tell me, there is some disturbance of it, can that be clear? I would just request the moderators of this session. Yeah, okay. So can anyone tell me what is wrong with that complaint and suggestion box? This was put in a municipal hospital because they wanted to improve the patient's care. Yeah, can someone put in the chat box?
Height of the box.
Height of the Dr. Desai, absolutely right. It is put at a level where nobody can reach. So if a treatment which is high tech, is available, but if patients cannot reach to that treatment, it is of little value. And this is what happens many times in children's orthopedics. Okay, we see again that people take shortcuts. Like when there is genu valgum, people will say do massage, go to bone setter, just give vitamin D, but that's a shortcut. It's not a solution. It's like wearing a t-shirt with a seat belt on it. It doesn't protect you from accidents. So what is required really is to make sure that when we are treating children, if you can see in this video again, you want to share the treatment. Okay, it's not important just to share the treatment, which represents the chocolate in this case. Because if the people don't have means to eat this chocolate, they don't have teeth, this is not going to help. You also need to share the teeth. Okay, so it's very important that when we make treatments possible, it reaches a common person. We make it available for a common person, and we always do it here at SRC Hospital through arranging camps, camps in interiors of India, in different parts of, make it a point to reach all out, through train, bus, conduct camps wherever possible, so that we can reach out to people who deserve this treatment. And we also offer financial help. We also conduct a lot of training programs for people all over India and across the world, so that these treatment methods orthopedic surgeons can run. And Dr. Avisha is going to organize a similar course, in next month, where a lot of doctors from all over India are going to come to SRC Children's Hospital to learn these techniques. So it's important that in some way we are able to reach out to people through education, through philanthropy, through charity. And we will always be available here at SRC Children's Hospital, though it's a private hospital, to help patients who cannot afford state-of-the-art treatment. So with this, I really want to thank Dr. Asik Shah and the organizers of this master's class for bringing us all close. There are close to 150 participants on this panel. And when Indian Railways completed 150 years, Morparia made this cartoon saying that they said that it's 150 years of bringing people closer. And when those who have traveled in the local trains really feel that it brings people dangerously close together. But this is an excellent attempt by which we are all able to interact and learn. And I thank everyone for being here at 4:55 in the evening and attending this session.
Thank you, sir.
You,
excellent,
everybody.
Yes, sir.
Thank you.
Excellent, sir. Excellent, Dr. Nagda, sir. Excellent example.
Thank you. Thank you very much.
Thank you, sir, for going through these common conditions and telling us about these conditions from what you have learned from your vast experience. So if anyone else from the delegates, if they have any questions they would like to ask, sir, I mean, you can write them in the chat box, or you can just unmute and ask. All right. So, so till we wait for questions from people, like, I mean, I have learned a lot from you, and even in this young age, I've changed few things in my practice from your experience. So, sir, like all of these kind of conditions, like a lot of conditions which you have described are still visible, and they can be seen and people know it is there. But in pediatric orthopedics, there are a lot of conditions which are not so evidently visible from the outside as well. So like what is there any like general something you would like to tell, because we have a lot of family physicians and pediatricians in there, is like, when should they at least pick up and start sending these children? As you rightly said, every child should see a specialist for these kind of conditions.
So I think that's a very important question, Avi. I feel whenever in doubt, refer. That should be the dictum. So if you see a child with genu valgum or a genu valgum, if you don't know what is to be done, refer. If the child cannot come here, you contact any one of us, send an image through WhatsApp, and we will be able to tell you whether the child needs a reference or doesn't need a reference. It's as simple as that. I've seen many times DDH or serious conditions being missed because the mother complains that my child is not walking properly. And, many times the doctor or the pediatrician will tell them, ki ho jayega, don't worry, things will happen fine. And then finally that child at DDH, and, we have to operate, and something which could be treated very simply with brace or a plaster. I've seen it happening in families which are close to me. I've seen it happening, with families which have doctors in the family. Doctors' children, they have a problem, and then they shy away from taking, opinion at the right age. So what I would like to say, I think, Avi, is that whenever in doubt, refer or at least take an advice. There is nothing wrong. You don't lose anything.
That's an excellent point. So there are few questions in the chat box. So Dr. Bagdi sir has asked, like, if there is a post-septic arthritis, hip sequelae, is that more common than CDH in your experience?
It depends. So previously, when I was a resident, hip septic arthritis in India was much more common than DDH. DDH, we felt in India doesn't exist so much. More common in European countries where, swaddling has to be practiced. Over a period of time, we have realized that septic arthritis incidence has gone down because the incidence of DDH has gone up. Not because it has gone up, because it is picked up now. And I'm very happy to say that previously we used to say we only neglected DDH. Child who is 5 years, 6 years, 8 years, 10 years. The oldest person I've seen with a missed DDH, which we have operated, is 25-year-old. Till that time, it was not being treated. Okay, but now we get references. So many times we have seen child who comes as 6-day-old child, or a 2-month-old child, or a 1-month-old child, beautifully diagnosed by a pediatrician or family, or at least screened, or they felt that the child has some problem and referred, and we've done a timely treatment, and the entire problem of surgeries and the problems with that have been avoided completely. So I think it will be a big service if if you use the small tips which are given in this talk, and Bipin has shown so many examples. I have shown few, and if people can use that, it will be very helpful.
Definitely, sir. So a few more
Yeah.
small questions. Dr. Kulkarni has asked.
Any further questions? There are few. Yeah.
So they have a
Yes.
child who has trigger thumb at 5 years without pain. So they're asking what would be the management?
Yeah. It should be treated, because the trigger thumb is like this. We need this. So all of us give thumbs up, and it need not be only on WhatsApp. Actually, this is very much required to hold things. You cannot hold things like that. You need a complete extension. And I would give a good news that a trigger thumb till 1 year age, if you massage, can reverse, can be treated without surgery. So normally trigger thumbs which don't respond to conservative treatment, massage, splints, by 1 year age, we operate. Okay. Before 1 year, they don't need surgery. And second good news I want to give you is we don't need an open surgery now for trigger thumb injury. We do ultrasound guided surgery with a needle where there are no stitches. Within 2 hours, child can go home, and this can completely turn into this thumb, a normal functioning thumb, just by a daycare surgery, where no plasters, no therapy, nothing is required. So, till 1 year, in summary, we don't need surgery, but after that, as early as possible.
So I think Dr. Kulkarni has written, if it is locked in extension position and
But
not,
even if child is 5 year or 6 year, it still can be treated.
so he has also mentioned if it is locked in extension, which is rare, but I think we need to assess the child before can comment.
Yes, we need. Yeah. So there are a lot of times children which are diagnosed as trigger thumb, they don't have trigger thumb or a finger. That can be a second, some other diagnosis. So definitely, these children need to be looked at. But I would say they need to be treated even if painless. I think the question was, if it's painless, why to treat? Even if it's painless, it needs to be treated because it is a functional disability.
That's great, sir. I think Dr. Kedar Ort has written that he basically was wanting to know, we as a department and as SRCC, do we have public outreach programs, and how do we engage with the community and parents in educating regarding about this early identification of all of these problems? And I feel as a department and unit and just hospital, we do quite a lot, and sir also is a part of many things, and he can also comment on some of those.
So there are various programs by which we reach out to community. One is we have charity programs with Rotary Club through Government of Maharashtra, things like that, through which we are able to screen these children and treat them. All of us have been part of these programs. Some of us who are young also travel. So like Avi has been going for a lot of camps, Jaideep, Mandar, all have been traveling, and they do go to community and conduct camps in interiors of the state, and those patients come here and get treated. And also, we also have a digital program by which, through online consultations, also we can consult children who, I have many children who come from out of India. We consult them through online consultation, and they come here and get treated. So I think we are not world famous only in Worli or Tardev area or area surrounding SRCC. I think we do treat patients from all across, and we want to continue to do.
Thank you so much, sir. Are there any more questions which anyone would like to ask?
Last thing, help us to diagnose things early, and what we can do is, people who have attended this program, we can send them the DDH and CP hip guidelines, the PDF, so that they have some material they can keep in the clinic and look at how to screen the hips and how to treat them.
That's a great idea. So we'll try and share the protocol, which sir has also been a part of in developing the DDH and cerebral palsy, the hip care pathway for all physicians. So it can help everyone to pick up and at least refer at the right time, because in these kind of conditions, the earlier you send, as sir has shown, the results are remarkable. So, sir, one more question is, basically, can you give a small overview on the limping child after fever? We know it is very common. Just your basic algorithm of what you would follow.
Yeah. So 3 diagnoses, limping child with fever. One is infection. You have to rule out infection. Best done by doing an ultrasound or an MRI and the blood test. The second diagnosis is an inflammatory problem. We see it very commonly nowadays. The child has fever and then he limps after a week or 14 days. The child is otherwise comfortable. The fever has passed off and then the child is limping. This is something known as transient synovitis. And that can, that can be treated just by waiting and watching and giving anti-inflammatory. The third condition where child has fever and a limp are serious conditions. There can be rheumatological problems like juvenile inflammatory arthritis. There can be tumors. So, they also need to be looked into. But
sir,
those
what
are
is the
rare,
first condition?
fortunately.
First condition, please repeat, sir.
First condition is infection, septic arthritis or an osteomyelitis. The second are group of condition called transient synovitis or reactive synovitis. And third are, a limp and fever, which can be secondary to a tumor or a rheumatological process. So these three broad,
So one more question, Dr. Jayandilal has asked, can we diagnose DDH on ultrasound in fetus? So I guess he's asking before.
Yeah, so it can be picked up sometime, but it's important to realize that most of the hip dislocation occur during birthing process, not in utero. So if the child has hip dislocation in utero, it is known as paratological hip dislocation. Not very common, but it's very difficult to treat. So you don't want to have a hip dislocation being diagnosed in utero, because that means that it's going to be very difficult to treat. Most of the dislocation happen during birthing process. Or immediately after that, or up to 4 months in the child till 4 months age. And the Pediatric Orthopaedic Society of India, in the guidelines has said that hip X-ray for everyone at 4 months age, which is very important to now screen DDHs in our country. Not ultrasound, but X-ray at 4 months age.
Sir, in some child, when we give injection as anterior upper 1/3 and lower 2/3 anterolateral thigh, we give injection. After giving injection, child starts limping. Then what are
reactive myositis or reactive synovitis, and treated with anti-inflammatory and ice. That should be okay.
Thank you, sir.
Anyone else has any questions? So till someone asks, I'll ask, sir. Like, sir has been in practice for quite some time, and he's been since pediatric orthopedics has developing, and now is hopefully established. And for a lot of conditions, sir would have seen a lot of things changing. He has changed treatments in time, and a lot of developments has happened regarding that. So even for some basic things. So, sir, at this point of time, I mean, where do you feel we are, like, from where we had started and now, like, most people still would think we are not able to offer everything what is available elsewhere. But I think sir would be able to answer that where we are at this point in time and what do we offer.
So we are very much, in tandem with what's happening throughout the world now. So I'll give you an example. When a television would be launched in Japan, India would get that television after 5 years. When a car was launched in USA, an iPhone is launched in US, the next day you have iPhone in India. So that's true even about medical technologies. The knowledge transfer is very rapid. All of us are, very updated. And we are here to offer global services. In fact, I would put it other way around, that there are a number of inventions or innovations which are done in India now are followed by the world today. It's a reverse drain. Previously, we used to go to US for fellowships and learn. Now people come from world over to India to learn. And I think it's a very important sort of indication that as a medical destination, India is on par with anything in the world. Again, to answer the second part of the question, the things will evolve. Whatever was future, whatever is future of today, will become present of tomorrow. Okay, and whatever is present of today will become past of tomorrow. It's going to happen. The dial phones are out, mobile phones are in, and soon we will not even be holding phones. There'll be virtual phones and communication devices possible. So life is here to change, and the fun is to live, with those progresses, but holding the principles of past true. The ethics and principles never change, Avi. They will always remain. So That will never change. Thanks.
Dr. Jayantilal has asked, he wants to know a little bit about slipped femoral epiphysis.
I think I'll ask Avi to talk about that because he's a hip expert with us. Avi, could you just answer that question?
Yeah, so basically slipped capital femoral epiphysis is one of the emergency kind of conditions which we say, where the there is it's a type of injury where the it's a misnomer. So we say the capital femoral epiphysis kind of slips and it forms a deformity, but actually it is the deformity of the femoral neck which moves away, and it needs to be fixed urgently because there can be issues with blood supply of the femoral head. And as soon as you see a child with that or diagnosis, they need to be referred quickly to a pediatric orthopedic surgeon who deals with such kind of conditions. Are there any more questions?
Avi, I'll need to leave because there is an emergency patient.
Thank you so much.
I think let's wind up this session and let's have more of these in future to come. Thanks everyone for joining again, and Rasik and the entire team, thanks for having me.
Thank you so much, Taral sir, for being a part and for this excellent talk. And thank you everyone for being a part of today's masterclass. If at all you all have any questions, please be sure to send it out to us. And I will try and forward the DDH and the CP care pathway, which has been developed by the IAP and the Pediatric Orthopedic Society of India. For your knowledge, we'll try and send these out to you so that you can also help implement these and put them in your. And thank you so much for being a part of today's masterclass. And I would again like to thank the entire masterclass team, my co-moderators, Dr. Rasik Shah and also Dr. Sonu Udani, who are a major part in this masterclass happening. Thank you so much. And we look forward to seeing you again for the next masterclass. We will be shortly sending over the details of what the topics will be there. Thank you so much, everyone.